Wonderful. Good morning. Okay, good morning. Welcome, everyone. Welcome to our fourth and last meeting as a part of our telehealth and virtual care meeting series as a part of the Action Collaborative on Countering the U.S. Opioid Epidemic. This meeting is very aptly titled, Where Do We Go From Here? And so this will be a bit of a summative meeting, also an opportunity to really look ahead in terms of how do we take all of the information that we've gathered through this meeting series and really put it together in our final roadmap that we're developing that'll highlight actionable opportunities for the way forward. And I just wanted to also thank you all for being a part of this meeting series, for participating, for really bringing valuable insights to this. I think this has been, I hope, a very interactive and valuable meeting series because we have had this, two-way dialogue throughout the series, which we'll plan to continue today. So if we can move to the next slide, just quickly walk through our agenda. So we will spend the first part of the meeting really going through some of the themes and learnings across the meeting series as a whole. And then we'll also have a dedicated presentation and discussion on effectiveness and accountability, which is something that is cross-cutting and will be a nice way to cap this meeting series. We'll then plan to have a break, and then we will have a session with several different breakout groups, which will be themed. Again, what we'll do is share barriers and opportunities. Hopefully all of you had a chance to go through some of the meeting materials in advance and really reflect on some of the questions for discussion that we've outlined. So this will be an opportunity to really hear from all of you in terms of important areas for us to really move the needle on as we move forward. So we look forward to your engagement and participation there. We'll come back after the breakouts to have a debrief with everyone, and then we'll plan to wrap up at noon Eastern. So if we can move to the next slide, I think we have just a few logistics and ground rules. I don't think I need to go over this at this point. We've been through this several times, but I think what I will just highlight is, again, we really appreciate your participation. So please do speak up. Please use the chat. We are capturing all of this, all of the input that you all are providing, and it goes into the proceedings, and we'll also go into the final roadmap that I mentioned. So please do participate as much as possible. And the other sort of related note as well is, we want to hear from as many of you as possible. So please do, share your perspective and do try to keep your remarks brief so that we can hear from the range of perspectives that are represented here. Okay, if we can move to the next slide. A special thank you to our planning group members who have really diligently worked on putting together this meeting series for all of you. And you can see their names listed here on the slide. It's been a really great opportunity to be able to work together, looking at the pain management as well as substance use disorder perspectives, and really trying to bring them together through this meeting series. So thank you to our planning group members, as well as to the NAM staff that have helped put this together, particularly Noah Duff, Emma Freiling, and Bailey Ravenbaugh. And with that, I think we can move to the next slide, and I can hand it over to Helen and Kelly to really walk us through a recap of what we have really learned from this meeting series so far. So over to you all. Thank you.
Wonderful. Thank you so much for joining us today. Kelly and I will tag team this. We were joking that after endless calls and meetings, we tend to finish each other's sentences at this point. So we're just going to kind of let this flow pretty organically as we go through what we've learned so far. And really what we've learned so far has come from you. This is very much trying to recap what was shared as part of prior sessions. Speaker slides literally lifted with attribution into this packet, so we don't have to redo what you've already explained so well. So with that, if we can just go to the next slide, I'll open it up and then turn to Kelly on the first issue. So the key themes we've identified so far across this series, and this is our fourth and final webinar today, is really that we need some standardized terminology and definitions. I'm going to turn to Kelly to go through that in a moment. How important it has been to have patients and family and those with lived experience being partners and transforming new systems of care. And I would also add being partners with us in building some of our tools, like the patient journey map that I'll share in a bit. Very much this idea that this isn't really telehealth or in-person care, it's just care. And at the end of the day, what do these future hybrid integrated models look like that we think very much for both pain management and substance use disorder are the future? And that's going to be a key part of one of the breakout groups today. We recognize there are still lots of clinical challenges to virtual care for pain management and SUD, and we need to increasingly go through and share best practices. No shortage of regulatory and payment challenges, as we've seen. They continue every week. We see new challenges that emerge here, but the fact that it limits the consistency to quality virtual care for pain and SUD care, but particularly across state lines. And I see Hank is with us, which is great, from FSMB, since I know that continues to be a major issue. The digital divide continues to be a challenge here. It's certainly worse. It risks worsening inequities if we don't address it. And we need more data and research. And Kelly is co-chair of that group for the overall collaborative on value, effectiveness, implementation requirements of what's needed. And ultimately, we need joint accountability across a whole range of stakeholders to really build the best possible systems that improve outcomes. We built this from the get-go being about SUD, OUD, and pain management. I will offer, and you'll certainly see that from Atif's slides as well, many of these lessons learned are really quite generalizable beyond pain management and SUD. So with that, I'm going to turn to Kelly to walk through the first set of slides. Kelly.
Great, thanks, Helen. Just moving through quickly, next slide and next slide, terminology and definition. So we start with, what are we talking about? And the answer is we don't have any consistent nomenclature here. So the HRSA Rural Telehealth Evaluation Center has a report that we recommend you all take a look at on current healthcare definitions. And we're really looking at something that comes close to a word salad. Next slide. Because if we look just at federal definitions, HRSA is defining telehealth as the use of electronic information and telecommunications technologies to support long-distance clinical health care, patient and professional health-related education, health administration, and public health. Okay, so that is being used a lot at different federal levels, but CMS is defining telemedicine as two-way, real-time interactive communication between a patient and physician. And that's the traditional old-school telemedicine. NIST is defining telemedicine as the electronic exchange of medical information. So when they looked in the study through all of the organizations and federal agencies, that of those they reviewed, only a third represented telemedicine as having a clinical care focus. And I didn't do this math, but the whole other half included CME and administrative processes. So normally as a clinician, we don't think about electronic billing as telemedicine or telehealth, but these are some of the definitions we're dealing with. Next slide. So part of the issue we have with that is that there are regulations and laws and et cetera being written using terminology that don't kind of cross-reference across different themes. We have this great slide that Lou Levy gave us talking through how at Teladoc they look at digital diagnostics, digital therapeutics, remote patient monitoring, e-consultations, and telepharmacy, all as sort of different buckets. And this is an example of, in the real world, how an organization is structuring this. Next slide. And something we heard that's really important is digital therapeutics or digital treatments are not general wellness apps, and there's an issue of not understanding the differences among all of these different terms and what they're supposed to be doing. Next slide. So in that HRSA telemedicine article is a large scheme of a concept map for how to even structure some of the definitions. This is one example of what's out there, but the idea that we need to really understand this better and come up with some appropriate language is repeated. Next slide. And we had a construct of how this is being used in a clinical healthcare system as one presentation, talking through all of how they're utilizing these wide range of virtual care modalities and technologies within a healthcare system. So next slide, sort of a bottom line here is who's going to standardize these? And that might be something for, as we get into breakout groups, if you've got any concepts of who might be able to do that, that would be something great to discuss. So next slide, and I think, Helen, you want me to keep going at the moment? Or
I'll go, that's fine.
Okay. Great,
so we can go to the next slide. So we wanted to give you a bit of a perspective of what we have seen, and some of these slides, again, we've used with attribution. This is Ed Mariano's slide from the VA, just as an example here of how, in their experience, how video telehealth encounters have been particularly impactful for patients with chronic pain and SUD, clearly increased access to peer support, and that came up in our live convening last week as well. Case management, counseling, care providers, particularly in rural areas, which may have limited workforce. Interestingly, I was on the HRSA, I moderated the final session of the HRSA telemedicine meeting about a month ago, and the head of the National Rural Health Association said, there is no rural health without telehealth. I mean, it is truly part and parcel of what needs to happen for that to move forward. We heard from patients, and this is what Ed had shared, but again, this ability to be flexible, to schedule and manage and attend appointments. For those with pain, really, we heard from patients in our session as well as from Ed here that patients, it's really hard to get in a car with a migraine and drive an hour to a meeting, to a session. So really being mindful of the patient benefits to this as we think about, particularly as Atif talks about effectiveness next. A lot of this voice of the patient strongly suggests great benefit to them from these opportunities. And that, particularly with SUD, and you'll hear lots more about this from Kelly, the importance of having regulatory flexibility to allow us to increase access, waive drug testing, and things along those lines. Next slide. And we also heard, though, that there are lots of challenges. Not surprisingly, we think about this, still really hard to access care at times, with lots of potential issues around security and exchanging information, concerns about privacy. We heard patients finding if you don't have access to high-speed internet, and you then have to go to a library or someplace else, you kind of lose your ability to have the privacy there. We heard continued issues around interstate licensing of patients having to drive across the state line. I just did that with my son. We live in DC. We drove across the Maryland line for him to continue to have his telemedicine with his person for his ADHD meds. It was the most ridiculous thing in the world, but we did. And we sat in the car and I got coffee and he finished his visit. I mean, this is just madness. There are difficulties certainly navigating different systems and processes, and we've heard a lot about that. And something we talked about a fair amount on these telemedicine tweet chats that I see Matt is on, that we've done a lot of these discussions about, are there actually potentials as well for misdiagnoses if you don't have the full ability to have physical exam, and digital literacy, as we'll talk about in a moment as well. Next slide. We also heard that really to leverage these, we need to, again, we'll talk more about this, really think about what is a hybrid experience for patients. What's the best things that we can do with telehealth? What really needs to be done in person? And really combining that, I think, is the future. And that, at the end of the day, regulatory stuff, as Kelly will talk about and Atif will mention as well, what do we need to ensure that policymakers really can focus on what leads to best care for patients? Do we have that right data? How do we co-design these systems with patients and break down any unnecessary barriers? Next slide. Just to share for those of you who have been part of the collaborative to date, our work group, in particular, the pain management work group, is really focused on this idea of building out this chronic pain journey map, indicating where there are opportunities for action, indicating where there are key resources that we want to recognize, that how difficult it still is, even with telehealth, to access a specialist in pain management or SUD, OUD. There's still a limited number of folks, even with telehealth, and really giving patients and clinicians resources, and then targeting this as well to what health plans and others need to do and use to move this forward. You can, happy to share the link for this. It is available. It is live. You can click through it and click through all the barriers and resources. And it's very much a living, breathing document. We would welcome your feedback about additional learning resources and other things we could share. Next slide. And there, I think we've talked about some of this. This is a slide from SAMHSA. Actually, maybe I'll turn to you, this Kelly, because this one's about specifically drug use.
Right. So when we're talking about treating opiate use disorder, really our gold standard is the use of agonist medication, buprenorphine and methadone. Buprenorphine is the medicine that can be prescribed by a doctor and picked up at a pharmacy. And so SAMHSA has looked at some of the data out there about the utilization of telehealth or TBOT instead of OBOT, or telemedicine-based opioid treatment. And there's a high level of satisfaction with patients. It's extending the reach of this kind of specialty providers doing this kind of work. No difference between starting them on buprenorphine on the rate of continued substance abuse or retention in service, which is a proxy for outcome and engagement in services. And the therapeutic alliance, so this is something we talk about a lot, right? Is this going to be something that you're not going to make that patient, doctor, patient, provider, patient relationship? No changes in the ratings of that using the telehealth technology with TBOT. Next slide. And sort of back to, some of these larger issues, and we put some of these slides in just for you to look at later, sort of not for us to talk through them all. So these are references for you on these issues. So next slide. And now back to Helen.
Yeah, and on that last slide, just to note the fact that, significant patient benefits in terms of parking time, things that might be more difficult to track as we think about the effectiveness and value, as Atif will talk about shortly. So hybrid integrated models, I've mentioned this already. This is a slide, I believe this is also from Teladoc. This is an example of the future is not either or, but this very much the idea of hybrid integrated care delivery, and that a lot of what we had heard across the different groups, and I see Dr. Talbot on with us as well today, who did one of these talks for us, the ability to pull together multidisciplinary care teams for chronic pain management is something that is really difficult to do in person. So the idea is also not just recreating what we are doing in person, but really thinking about new models of how you do that, how we can reduce disparities, access to specialized treatments. And we've mentioned much of the rest of this. Next slide. Couple of examples we heard of comprehensive hybrid SUD models, VA's clinical resources, Common Spirit presented their telehealth MOUD, Rush shared their substance use intervention team. Lots of key learnings, focus on workflow. Clinical pharmacists, and I'm really glad Anna's going to lead one of our work groups to follow, are really key as part of this workflow and thinking about how to do this well. Lots of virtual tools, as Kelly started at the beginning, and then really thinking about how this fits into alternative payment models going forward, particularly as it might help us scale those hybrid care models. Next slide. And I'm not going to walk through these. This was a couple of slides we have just for example of what it looks like to walk through the patient journey of thinking about a telepain program in this example. It's just not simply taking what we do in person and redoing it. It is very different multimodal opportunities and really thinking about how the whole care team operates. Next slide. Actually, we just did this one. Next slide. And this was another example, again, from Ed, thinking about, particularly for the pain care model piece of it, what does it look like when you're thinking about moving from acute pain to avoiding chronic pain at the end of it? And we recognize how much of opioid use disorder stems from chronic pain, acute pain, and continued use without clear assessment of switching to different resources, post-discharge, other meds, for example, and really thinking about opportunities. For example, they have a post-op clinic that they've been using just to help people ensure they have what they need to avoid getting to the place where they're moving into more chronic opioid use. Next slide. Again, this just highlights us from Common Spirit, just the importance of thinking about workflow. This is particularly about opioid stewardship, and again, the importance of the PharmD, the pharmacist here, of taking that information from patients and ensuring that patients get what they need across those transitions in care. Next slide. Another example here of a substance use intervention team I mentioned from Rush, the SUIT program, really not just thinking about pharmacists here, but I think emphasizing the importance of the whole team. Here there are inpatient nurses, social workers, moving and sharing and making that appropriate transition to outpatient clinics. And mental health was a really important one we heard as well for so many patients who have both of those issues dually. Next slide. Clinical challenges, maybe I'll turn to you for a little bit here, Kelly.
Sure. So, again, we're discussing what are the possible clinical challenges, and we heard from a number of people. Just to remind you about the technological issues, the concept of therapeutic alliance, the issues around risk and liability for the clinicians, quality implications, and a lot of these we don't have data on that we're going to need to do research on or just capture elsewhere. And then we have an issue with over-regulating what's required to provide care. So there's a long intake times, particularly for OUD treatments, and that can get in the way of rapid patient engagement and care. And it's much easier for patients to move through and just literally sign pages in person than it is in a tele space. Next slide. Oh, let me go back to the key issue here. As one of the quotes was that my patients say it's easier to walk out the door and access fentanyl than to access buprenorphine or methadone treatment, which are the evidence-based gold standard core treatments for OUD. Next slide. And so talking about, what are some of the ways around these or what we need to do to address the challenges. Determining what inpatient physical exams are acceptables and exceptions, some of the things that you'll talk about in breakout groups. Next slide. And here are just some lists, again, for you to go back and look at about sort of the potential benefits, potential drawbacks of telemedicine. And we talked, just reminding you, we talked through these in our earlier sessions, but the slides are here for your reference. Next slide. And similar sort of takeaway issues, and some noticing some updates in the CDC's clinical guidelines. Next slide. So regulatory and payment challenges came up time after time, and let me just kind of talk through these because I'm sure these are going to come up in your groups, and I'm sure that Atif is about to talk about some of these. But if we look at sort of the big regulatory schema that see here, the insert from Bicycle Health, the telehealth and regulations. There's a Venn diagram interaction with all the regulations we have around opioid use disorder treatment and the regulations around pain treatment with prescribing of controlled substances. And so here we get federal regulations, state regulations, and medical boards, and the most restrictive of those holds in any jurisdiction. So we heard repeatedly about how important it is to focus on state level medical board and state regulations. There is that competing focus on getting access to appropriate treatment, but also decreasing the risk of diversion of controlled substances, and a huge issue of the Ryan Haight Act expiring, and our need to do something about that. Next slide. Sorry, next slide, please. Great. And again, the discrepancies in language, oops, backing up one, thanks. The issue of audio only telehealth, which came up multiple times. Again, there's issues, there's issues of an equity issue with audio only, with expanding access, but there's a double-edged sword there that was brought up because there's a potential decreased quality of care with the audio only. And then of course, the lack of metrics on appropriate care.
Also, just to jump in and set up the next discussion as well. I mean, we actually don't know that there's a decrease in quality of care because we don't have very much evidence at all and how these modalities play out. And for a lot of patients, it's both preference as well as their only access is via audio only. So I think that's something that came up a lot, particularly from the patient community during our sessions. I just want to put a pin in that if we could. Sorry, Kelly, back to you. Right,
which sort of goes to the last bullet point here, which is last metrics on appropriate care. Right, so there's a focus on paying for performance and bundle payments and et cetera. But of course, we have to have process metrics before we get quality, before we get outcome metrics in place. So without lack of metrics that are generalized and understandable across stakeholder groups on what is quality addiction care, what is quality pain care look like in our current treatment as usual brick and mortar environment, it's hard to build them for telehealth or integrated when we've never built them for in-person care. Next slide. And we've got some information on the updates around some of the regulation that happened at a federal level and et cetera during COVID, which really pushed a lot of this. Next slide. And we got a talk here from United Health on how rapid this uptake was. And you can see the number of claims for virtual services. And a lot of this is driven by behavioral health services. And they're focusing on safety and then risk management. Again, next slide. And they gave some really useful slides, next slide, on how they approached this industry transformation around telehealth. Next slide. And they gave some definitions about fee-for-service and alternate payment models and value-based contracts. Next slide. We heard from the Association of State Medicaid Directors and how they are approaching looking at telehealth and its impact on the members of Medicaid members in their states with this really useful 6-point approach that they're using on looking at what's the member experience, how does telehealth impact access to care, equity, quality of care, the costs of care, and program integrity, which is around fraud, waste, and abuse. So these 6 bullet points are the domains that the state Medicaid directors are using to look at telehealth. And this is an example of the kind of great stuff that we've gotten out of this so far to help frame up looking forward. Next slide. And we also had discussions about payment parity. So do we pay, which means paying for telehealth in parity to brick and mortar in-person health, different than mental health and substance use parity, which we still don't have for substance use disorders and mental health in telehealth versus or brick and mortar versus the other medical conditions. And next slide. And I would point out that part of the output of this action collaborative was around a document on the guide for the future directions of addiction and the OUD treatment ecosystems, which delineated at depth the 4 C's of our need for capacity building, competency building, consistency in care delivery, and compensation. And this is the output of the action collaborative that has a strong focus here on compensation and payment issues. So I draw everyone's attention to that output of this action collaborative. Next slide. And another list from David Gasper, the dynamic care, a construct of what we need for tech deployment around billing codes and dealing with all of our obstacles for regulations and our licensures and our need for quality and standard reviews that again, makes that line between for value, which is quality divided by cost. Next slide. I got
Great.
through that really quickly. I'm surprised.
Clock is going, Kelly's moving quicker. So I've talked a lot about these issues already around the digital divide. We just want to pull out some of the key slides that we saw during the sessions. Again, very much a sense that telehealth can increase access to care, but we need to avoid anything that causes inequities going forward because of lack of broadband access, digital literacy, tequity in general. And I think particularly for rural, low-income, older adult populations, while a lot of folks have smartphones, they may have broadband. It really significantly varies by education and income. In a talk I was recently part of, they also discussed the fact that it isn't just if you have broadband, but you also have to consider the cost of the actual use of the broadband. And so people may need to pay more if they use it for their visits, and some just can't afford it. Next slide. And this is certainly a factor, as you heard from Kelly, about using treatments, particularly via telehealth for SUD, and considering the fact that use of telehealth still is less likely, for example, among those who may need it most, dual eligibles who may also have mental health needs, Black and rural communities as well, solo practitioners, and those who are commercially insured in lower income counties. So we know there are differences there. And I think as the access group really talks this through, thinking about particularly what NAM can do, what we can collectively do to address some of these issues would be really important. Next slide. And this was some barriers, particularly for implementing video visits for patients with OUD, reported by their clinicians. And as you can see here, lack of patient readiness. Patients don't have the right devices, they may not have digital literacy, don't have broadband, are the top of the list, but there are lots of other issues around technology, lack of infrastructure. I had a telehealth visit recently personally with my clinician, and she could not get my audio to work. It was just like maddening. We both have broadband, this made no sense, and yet she just could not get it to work. Next slide. I think I already went through this. This just has, you can just look at this yourself and get a better sense of what those differences are, but that was already in the prior slide. Next slide. Data and research needs, I'll turn it to Kelly and then we'll wrap up.
Great, so next slide. So as we've talked through this at a very high level today, we've identified some of those issues. You know, what are these quality outcomes that should be our targets for managing pain and SUD? Looking at metrics for audio only or audio visual versus in-person utilization around those value metrics. Questions about the adequacy of telehealth visits and secondary visits are a huge issue with EHR interoperability problems, and the standards and the quality reviews that we're going to need, the utilization management pieces in place for virtual care modalities. And next slide. And so this is a pitch for you to say that with Carlos Blanca, we are the co-chairs of the Research Data and Metrics Group for the Action Collaborative, and put out last year a research agenda from the entire collaborative here. And the ideas for research that are generated in today's discussion and in the discussion that we've had previous will be given to the Action Collaborative. And the research agenda is going to be updated with this and the newly identified research needs from the other projects that have occurred during this part of the collaborative. So please throw out your ideas. You can throw them out in the chats. You can throw them out in the discussion. We will collect those ideas. So please, this is for us to, this is your chance to get that kind of input. Next slide. And then sort of the biggie at the end, joint accountability. We kept hearing about this issue. Next slide. And the issue is, who's going to do this? We need joint accountability for policymakers, regulators, employers, purchasers, payers, systems, providers, and patients. And we're looking at, this needs to be around coordinating our alignment of measures and metrics across delivery systems for treatment as usual as opposed to virtual care and integrated cares. And we need to focus on those baseline process measures before we get to value-based or pay for performance, right? You can save money this year treating diabetes, but if you're not getting, diabetic foot exams and retinal exams, you haven't made the baseline care. So we start with that before we go to anything else. And we need to look at those for across the board. And then investing in the infrastructure supports to ensure that accountability and drive improvement. So some examples, state needs to do oversight, actual oversight of their licensed providers, the payers focusing on quality utilization management, regulations built with clinician input, flexible payment paradigms, and et cetera. So as we go into our breakout groups later, what we really want from you is around who needs to do what to push forward the things that we have identified throughout the collaborative. So this concept of who needs to do what is something we really want to hear from you. And again, chat or in the discussion will be great. So next slide.
The dog was making noise. So before we turn to Atif, I just want to add that I just put in the chat a paper that just came out a couple weeks ago by Carlos Blanco, who co-chairs the research group, and Sherry Ling from CMS, who's on our pain management group, about the importance of thinking about what is that pathway from scientific discovery to covered treatments from a payer perspective. And I think part of what we've really been trying to think about is that broad that joint accountability lens. So I would really recommend that paper, and I just popped the full text in the chat. Wonderful. Thank you so much. With that, apologies to Atif for going over. We were trying to cover an incredible amount of information over the last sessions, and it's my pleasure to introduce Dr. Atif Mahotra, who many of us read regularly on telehealth in the scientific literature and elsewhere. And Atif is a professor of medicine and healthcare policy at Harvard Medical School, and is a clinician at Beth Israel Deaconess Hospital in Boston. So Atif is going to round us out what we felt like we didn't talk enough about, kind of pulling this all together, this concept of sort of effectiveness, value, and accountability. So with that, I'll turn to you, Atif. Thanks.
Thanks, Helen. Thanks, Kelly. Really excited to be here. My job is to prompt a conversation, not give you answers, but to prompt a conversation among all of us about what we really need about effectiveness, value, and accountability. And to give you a little bit of my sense of the perspective of the larger payer and regulatory community. So if we go to the next slide, so we can click through this again. I really wanted to emphasize that there, as you have all witnessed, there's just so much new models that are developing. And I did want to emphasize the second bullet point. We're 2 years into this, but we're still really at the beginning of that innovation curve. As has been articulated many times, so far, a lot of the model has been, hey, let's replace an in-person visit with a telemedicine visit. But I think that there's so much excitement and interest in new models of care that are coming beyond that. And really, a lot of the conversation I hope we have afterwards is what evidence do we need to support this innovation, and how do we ensure that this sort of innovation doesn't die out because of regulatory or payment issues. Next slide. Right now, as you've all been witnessed and you've discussed with Ryan Haidt and others, we're in this temporary payment and regulatory changes. We keep on kicking the can, we as a country keep on kicking the can down the road with the extensions of the public health emergency, and all those interested in this space are waiting for the permanent policies. What is that permanent policy going to look like? I've been lucky enough to have a lot of conversations with the legislative community, states, payers. I certainly don't know the answer, but my instinct is we're just going to kick the can down the road a little longer. That there is a general sense that there's a dearth of evidence, and that and writ large for telehealth and virtual care, whatever the definition might be, sorry, I also struggle with those words, Kelly, is that we're just going to kick the can down the road and say 1 to 2 years, we're going to extend the current policies, and there's going to be a call for evidence. Why do I think that? That's what I've been hearing, but also we've already started to see legislation of similar ilk at the state level, where states have said, hey, we'll expand, say, virtual health for primary care, but we need more evidence. And so it really does emphasize the importance of this topic. Next. So I wanted to go pull back a little bit. And before, we've obviously been focused on substance use treatment, opioid use disorder, pain management, but I really wanted to pull back and say, like, you can get caught up in the, this is awesome. Why does anyone object to this? This is what we need. And I do want to provide that perspective. While I think everyone recognizes the potential for telehealth to improve access to care, there is this risk of increasing spending, and telemedicine's ability to make care convenient and more accessible. The key to its enormous potential to improve the health of many patients may also be its Achilles heel. And if I could just kind of illustrate that on the next slide here, next two slides, this is some work that was done, again, not focused on this clinical area, but just across all clinical areas. In some data that was done in the UK and the US, they said, look, of 100 people who become sick in the world, most people just stay at home. You know, they just fine, the rash goes away, their ankle feels better, their cold goes away. Only about 40% consider seeking expert opinion, and of those, 29 actually do get care, mostly going to their doctor's office. Next slide. So the point with this is telehealth will, that's the reason we're excited, is going to increase access and convenience. And that means more patients are likely to seek input. And given that convenience and more options, more people are going to get care. And so that's going to increase utilization and therefore drive up spending. And that's the major concern. And so, well, that's fine. Just to kind of pull us back to Health Policy 101, if that increase in utilization leads to better outcomes, yay, we're good. And that kind of goes back a little bit to the JAMA piece that Helen put in the chat about that's the perspective. Another aspect of this is it high value care? High value meaning improvements in care at a reasonable cost is another key issue. And then lastly, from the health policy perspective, there is a sense that when you provide these new innovations, you're going to have both. You're going to have high value applications for that patient in a rural community who otherwise could not get OUD care. But you also might have applications that lead to increase in utilization that does not translate into improved health outcomes. And how can we craft policy either through all the tools we know about, from copays to prior auths to other things, so that the care that we do result is concentrated on those who would most benefit. So that's just a high level thing on telehealth as a whole, and why there is a debate as opposed to let's go with this. We go to the next slide. So what do we need here in terms of this? So I wanted to emphasize, and this has been already echoed by Helen and Kelly, which is that what do we need evidence on? We need evidence on the utilization and spending impact, quality, specifically which conditions are best managed via this, which patients are best managed via telehealth. I do want to emphasize that beyond the payers, the clinical community is also somewhat skeptical of telehealth. They're a little leery, at least the work that we have done with surveys of providers who treat opioid use disorder. They're deeply skeptical. They're not sure whether this is good care or bad care. And so we need the evidence both for regulators and payers, but also the clinical community. Access and equity was already emphasized, the role of the phone visits, and also, as I'll touch upon in just a minute or so, the impact of new payment models and what impact they're having on this innovation. I do want to emphasize what are not critical evidence gaps. I don't think anyone doubts that patients and providers to some degree are interested that the technology can work, except for Helen's phone issue, audio only thing. But sometimes we have glitches, but most times people think this works. And there's no doubting that it saves patient time and travel. I don't think anyone doubts that. Now, I do want to acknowledge, and this is something that came up, I believe Chad Alomafil from Michigan mentioned this, which is, do we need to be, should there, in this particular component, should it be given the benefit of the doubt? And I generally think that that has validity when we talk about substance use disorder, and in particular opioid use disorder. We've already seen from payers and regulators that there is a general sense that we have a crisis in the nation, And at the end of the day, let's just try it because we got to do whatever we can. Well, we might have a very different conversation if we were talking about telemedicine for, I don't know, sinusitis, where there would be much more skepticism about that. Next slide. I do want to emphasize some pitfalls that I have seen among those who have tried generated evidence here, just to kind of put why I think this is important. First, a lot of excitement. There's so many amazing things that I heard described, and I believe that they work, but assuming that they will work is sometimes, I think we do need to make sure that there's clinical medicine there's a lot of stuff that we thought would work, and then when we really rigorously evaluate it, it doesn't work. So we just need to make sure. This is building on the lack of clarity on the intervention. So many of these studies get caught up in the kind of morass of what we're talking about problem. And so really delineating really what the intervention is, because it's going to be very hard at the end to synthesize this literature because each of the interventions is a little bit different. A lot of times understandably, in particular with substance use disorder, all of our focus is how do we get more people to get care? But we also have to acknowledge, and one of the reasons there is skepticism about those who are already getting care, and is the increase in convenience just going to get those who are already getting care more care and not let new people in? And then lastly, I do want to emphasize that there is skepticism from the payer and the regulators about comparing outcomes from those who receive telehealth versus those who do not. There is just general sense that the people, there's selection issues. People who are crazy enough to have a telemedicine visit are going to be different and in general healthier. And so there is a lot of skepticism of direct comparisons of those patients. So next slide. I wanted to also end here by emphasizing it's hard. Research takes a long time, but it's coming. And to not, and I just illustrated, I'm not sure if this particular paper was discussed in a prior one, but this is a group at Michigan who looked within the U.S., excuse me, the veterans, the VA system, and looking at telemedicine for buprenorphine versus in-person. This was published in JSAT just a couple months ago, highlighting that those who received telemedicine for buprenorphine disorder versus only in person were less likely to be older, less likely to be non-white, less likely to be homeless, and there were similar rates of comorbid disorder. And so, yes, there are disparities, but it was interesting and I thought important that the authors also really emphasized that, yeah, there are differences, but they had largely similar characteristics. There wasn't the discrepancies, for example, homelessness that they might have thought of ahead of time. So some of the results that are going to come from that may be a bit surprising. I'll just touch upon on the next slide a study that we have that's still preliminary, but hopefully will get out soon, where we looked within the pandemic and we divided up all the practices that treat opioid use disorder into two groups: those that have really embraced telemedicine and those that did not. And then within those practices, we tried to see what was the change in patterns. This is a diff and diff model, as sometimes people will do. If you go on the left there, the no telemedicine practices, they had about 2,200 to 2,300 patients each year, the year 12 months before the pandemic and the 12 months immediately after the pandemic. The number of visits per patient was actually somewhat almost exactly the same, somewhat surprising to us. We had expected a substantial decline. In the high telemedicine practices, similar patterns, similar number of visits, though 60 to 70% of the visits were provided via telemedicine. So that was just a really, in contrast to what I had described before, concerns about increasing utilization. Here is pretty much flat, that there was no increase in utilization. Then the question we wanted to know is, does this model lead to better outcomes or the same outcomes? And in general, we found pretty much the same in terms of how long patients stayed on MOUD, overdose rates, injection-related infections. One thing we were a bit disappointed in, but maybe not surprising given supply issues, the number of patients treated was similar also. We had hoped that the number of, with telemedicine, more people would start accessing care. And in this particular situation, these high telemedicine practices managed the same amount of patients. We did see less use of urine toxicology testing. So next slide. And just to wrap up, I also wanted to, when we think about what is needed for research, I do want to emphasize the payment side. we have had already from CMS an introduction of new bundled payment codes for the treatment of outpatient opioid use disorder. The goal of these new codes was to echo the OTP payment system. And when these were introduced by CMS, this is a quote from Seema Verma, it was really about encouraging innovation, trying to decrease administrative burden, trying to improve coordination. And it really was, here's a payment for your first month. I'll show you the codes in it on the next slide, as well as a monthly follow-up payment. Dr. Burston, just go forth and do exactly what you want to do and whatever model you want to choose. And so again, care coordination, psychotherapy, substance use counseling. Next slide. And here, just for those of you who are interested, the specific codes and what is encompassed with that. So it's a very exciting opportunity, I believe. By the way, these were introduced in January of 2020. A very exciting opportunity that if these kinds of payment codes are incorporated by providers across the nation, my view is that it could really encourage that level of innovation and decrease the administrative burden that so many of them face in substance use disorder treatment. The one disappointing thing that I've seen is that the uptake of these codes has been relatively modest. And so the one question that I have is, and I think is an important research topic beyond looking at the effectiveness, is these payment codes. The hope was it would drive in innovation. Why haven't we seen real uptake by providers? So I'll stop there and then turn it over to Helen and Kelly, I think, for a conversation.
Thanks so much, Atif. That was perfect. And I think you laid out a lot of the really important issues that we're going to talk about in that work group to follow. Team, can you remind me, I know we're a little bit behind schedule, how much time do we have for this chat? But in the meantime, if people have questions, feel free to put them in the chat or raise your hand.
I'll start while we're looking for
please,
that.
Go ahead.
For the time. So a great overview, and thanks for talking about the P-code model, which took many years and a lot of work from ASAM and AMA to put together for that bundle payment for the OBOTs, which could be used for TBOTs. One of the issues that we see in the field is that the P-code, those codes are not accepted by the majority of payers. And often Medicaid in particular doesn't accept those codes. So some of the uptake is, fee-for-service Medicare might pay for those, but those are the minority of patients who are going to be getting into the OBOT or the TBOT space. And then the other thing I wanted to ask about is you looked at it's great looking at the OBOT practices. And I think they were OBOTs as opposed to OTPs and OBOT practices.
Yeah, I did that quickly. I apologize. I jumped in, tried to describe it too. Yeah, but exactly.
Yeah. And so we've sort of found it hard for OBOTs to make the transition to TBOT as easily as it has for new TBOTs to kind of start from the beginning. And then there's a question of there are three different patient populations: the OTP, the OBOT, and the TBOT population. And since if we look at the uptake of TBOT in and of itself, that is increasing access, it looks like, as opposed to just expanding from the brick and mortar. So I wonder if you could speak to if you looked at that at all in the research. And then I'm done with my question. Thank you.
Yeah, no. So I should emphasize, Kelly, we're just talking the tip of the iceberg here. There's so many questions there. And I do think that I am interested and excited about this space because of the opportunity to improve access to care. But I think we need to empirically demonstrate that it is leading to more people getting care. And I'm very cognizant that while telemedicine may be an amazing way to increase the geographic reach, the specific thing of just, manpower or just the number of providers may really limit that from really expanding access in the way we want. So it's an empirical question. I'm hopeful, but we'll find out. I think you raised a really important other point, which is that, and this was obviously raised already by the bicycle health folks as well as others, which is that it gets so confusing with the different kinds of, like, if I was a Medicaid only provider in one state, it's a lot easier than treating patients across many states and across different payers, and specifically on the bundled payments codes. Although I think it is an interesting question and maybe worth mentioning in the report, like, why aren't Medicaid plans doing this? Why aren't the private payers ubiquitously adopting it? Usually when Medicare moves, people follow. Why hasn't that occurred in this case? So we do have a global pandemic that has led to people being distracted by other things.
Couple questions. Let's start with Dr. Taubman. Did you put your hand down?
Well, I can just want to first thank you for the great presentation, Dr. Mahotra. There is data on coordinated and collaborative care that has demonstrated that this reduces costs. I think the challenge is doing a randomized controlled trial and providing that particular access. Linda Barr is on the program group, and she's recently published 2021, I believe, and I cited the reference in the discussion, again, how that has been done. The VA has demonstrated this. So just your thoughts about, more people being seen, but you will long-term in a value-based system reduce unnecessary surgery, unnecessary visits, unnecessary consultations, and deterioration of patients in their overall status and function. So just some thoughts on pain and opioid use disorder really share the same house with getting the right people at the table, working on our patients with complex interspecialty requirements.
Yeah. So David, I appreciate the comments, and I think what you emphasize here, at least the study that you mentioned here, there's this little bit of a tension here, which is let's emphasize that coordinated teams and collaborative care, which have been demonstrated both in treatment, substance use disorder and behavioral health, have been effective. How much does that translate into virtual and telehealth? And do we need similar studies that are specific to those models? We can debate that topic, but I generally think that when I was discussing the evidence gaps, my lens was telehealth and virtual health, which is problematic because so much of the prior work, the studies that you highlighted, were done in the pre-pandemic world where that really wasn't part of the conversation.
Let's go, Sarah, and then Hank and I have been told we can go till 10:10, so we have a good amount of time. Sarah, please.
Yeah, so I just want to make a comment that I'll raise more later in one of the breakout groups is, when we talk about what works, what's effective, we kind of talk a lot about, and I think it's a nuance and a language issue. We talk a lot about buprenorphine, about MOUD. We're missing the psychosocial service component when we talk in a lot of our quick speak and in some of the research. So Dr. Mahotra, some of your slides, didn't really talk about, when you look at the outcomes, are you talking about buprenorphine alone? Or are you also talking about buprenorphine providers who also offered psychosocial services? And part of my concern is that, and we also don't talk a lot about OTPs. And part of my concern is that the OTP model is currently, there are a number of people who want to essentially deconstruct the model, but it has about 50 years of a full evidence base. And we don't know for buprenorphine providers how many of them actually offer the wraparound services. And so I am very concerned that in this time period when we have rising overdose rates, that what we know works, which is medication plus psychosocial services, is really getting lost. And the problem is that it crosses a number of the different issues that we've been talking about. So I think that in our language, when we talk about sort of definitional issues, we really need to figure out a way, because when people talk about MAT, they often are just talking about medication alone, not that it is medication-assisted therapy. So I just think the research has to get more nuanced, the language has to get more nuanced, and I think we need, more data on that.
I don't disagree with anything you said, Sarah, that in terms of both, but just to emphasize 2 points. First, there is a kind of a tension here when we talk about this area of how much is just about getting the medications into people's mouths or into their arms, and versus how much of it is the psychotherapy. And I think that we sometimes are not clear about delineating those two. And I also think, and I'll criticize my own work, which is that I'm available the data that I have available, and I can only look at certain outcomes. I can count up pills or how long people are on medication or overdoses, but I can't count a lot of things that are really, really important. And I think that's an important issue. And I think that's why we do lots of research studies, not one definitive study.
Right. Yeah, I also think it's part of what's kind of holding us back with the insurers. I mean, I think the payers, that's just a totally different issue as to why they're not paying more, for different kinds of services, given what we know about the long-term, cost savings. But anyway, that's it.
Thanks, Sarah. Hank and then Steve.
Thank you very much, Helen. And I actually have an observation and a question for Atif, but before I do that, I want to commend you, Helen, and Kelly and Aisha and the National Academy staff for putting together this wonderful series of telemedicine presentations. They've been very insightful and instructive. I agree with Atif that we are sort of at the beginning of this innovation curve, even though we're 2 years into the pandemic. I think about my own mother 2 years ago, 2 summers ago, when New York, where she lives, was sort of the epicenter of the pandemic. She began using telemedicine first time for a variety of reasons, safety, one of them, but also for convenience. But part of the reason she did that was because her own physician was also using telemedicine for the first time. And we've seen not only patients, but providers across the country experimenting, seeing the value of telemedicine. And I agree the future is probably a hybrid version of that. But my mother's doctor was within the state. So as we talk about regulations and what we can do forward, I will mention that the FSMB's House of Delegates just at the end of April adopted a series of recommendations that we had put forward to sort of be more open to medicine. And you can see the policy at our website, fsmb.org. We had input from AMA, we had input from AOA, we had input from the American Telemedicine Association. And so the state boards are trying to do the right thing. But my question for Atif is, do we know what percentage of telemedicine use, whether for pain management or substance use disorder or generally, was utilized across within states? I hear the issue about interstate care, but my sense is the majority, from data that I've seen, the majority of that has been within states.
Right. So Hank, thank you. It's an important topic, which is that how much of out-of-state telemedicine, is there? To give you some numbers, at least from our work and some recent work that was published in Health Affairs, roughly 5% of telemedicine visits are out of state. Those visits are predominantly by those who live within close to a state border. Helen is the prototypical example in DC, where I think it's 36 or 37% of DC residents of their their telemedicine is out of state, because it's mostly to Maryland and Virginia. We see that the dominant uses of that telemedicine are for primary care and mental health treatment. And so those are a couple of facts there. I don't see, I haven't specifically looked at substance use disorder, but I generally think that that's more in line with the other clinical areas. And I think lastly, it reflects mostly situations where people have gone to those providers for a long time and are now wanting to see them via telemedicine.
Okay, that's very, very helpful, because I think for care within jurisdictions, the FSMB is trying to nudge the states, and the states are open to it because they've seen the value of telemedicine. I believe telemedicine is here to stay. For interstate care, even for that small percentage, that's where something like the Interstate Compact could come into play. Maryland and DC are part of the compact. DC hasn't fully implemented it yet, but that could be a way to address some of that, but we can talk about that later. Thank you.
And I just want to, while 5% might sound small, I just do want to emphasize it's a lot of people. Hundreds of thousands of people are getting that care. So it kind of depends on where your perspective is in terms of how important it is to you specifically as a patient.
Absolutely.
Yeah.
Both groups are important.
Yeah, and thanks, Hank, for your report. It was very, very helpful. I will say, I think it's also very disproportionate where that 5% lays. I think we're seeing lots of examples, for example, of patients with cancer care and others where getting to that, right center is limiting. So I'd be interesting to see if that does translate over to OUD and pain management. Before I turn to Steve, Kelly, I see you've been having an exchange with Eric on the chat. Anything you want to share with the group? Because that looked important.
Oh, I don't know. We've captured it on the chat. So Eric was talking about the payers who've developed a number of different, HCPCS codes for capturing bundled payment rates, which are inconsistent across lines of businesses and providers. And on the Medicaid side, there's a lot of variation in what states are going to allow managed care organizations to do in terms of putting together bundled rates and et cetera. And so I would discuss back that there could be a baseline of simply turning on those where allowed by contract, just turning on those PCODE codes that Atif had mentioned, and then allowing the flexibility for the payers to be negotiating individual HCPCS codes for different rates for be flexibly with the kinds of providers giving different treatment models and et cetera that's available within their community. And one of the issues we have is that, sorry, I'll leave the rest out there, and because I'd love to hear what Steve has to say.
Wonderful. All right, last question, Steve. I'm sorry, Atif, go ahead.
Just really briefly, it sounds silly, but I do want to emphasize the point that was just raised by Kelly, or maybe touched upon by Kelly, how important it is. It is nuts for a provider to figure out how to bill telemedicine. You got each of the payers. Well, Medicare alone has so many different ways. It's not easy a single way to do it. And there's a lot of myriad of codes. The commercial payers generally are similar, but Medicaid, it's remarkable as we've looked from state to state to state to state. It is very, very complicated in terms of Ohio might have a different set of rules than Missouri than Wyoming. And I think you get it where it comes from. Each state is like, okay, what do we want? Not thinking how consistent we are with other, but when we talk about telemedicine, because you have to go across so many jurisdictions, it gets complicated. Again, silly, but really important. Sorry, Steve, I cut you off there before you had your chance to ask your question.
Oh, not at all. First of all, I really appreciate this discussion and the presentation. Even rapid fire at the start was terrific. I'm one of the co-chairs from the education and training group in the collaborative, as you know. But having not been able to attend the past meetings, I appreciated sort of the Netflix, like a rapid fire recap of the last season. So I appreciate that. So my question, and it will not surprise Helen and Kelly at all, but it's very exciting what you're describing, and something that really, a few things that hit me is, one of you mentioned, that this is not telehealth, it's care, right? It needs to be, the language needs to be normalized. We're in sort of an exciting period of kind of open flexibility and experimentation because of the crisis of the pandemic. But coming back, especially Atif, to your last comments, I wanted to ask about how we bring continuous learning focus into the approaches that we're taking. I know that the AAMC did some great work, I think last year or the year before, in developing competencies across the continuum related to telehealth skills. I'm interested to hear what you think about the ideas of performance management, continuous education, and ways to, through a continuous learning lens, to connect this work in telehealth, particularly for practicing health professionals. Interprofessionally, I'm talking about behavioral health and physicians and pharmacists, et cetera, to wrap this into a learning framework, just like we are trying to wrap, sort of in the education and training group, we're talking a lot about how we address gaps that we have observed in lots of different settings. again, around continuous learning. Can you just respond about how best do we plug in and put our work together?
Yeah. Well, Steve, I mean, I think, it's interesting on this specific point. This is a topic that I'm not that worried about. And you should tell me, you should push back if you disagree. But my general sense in clinical care is when we just, surgeons move to laparoscopic surgery, training and continuous learning adapted both on the, trainees as well as those in practice. When we have new modalities and other ways, we start training and also we have an apprenticeship model in clinical care. And so now that care has shifted to the telehealth side, and maybe I misunderstood your question, I feel like we've already seen a shift and we will continue to see a shift as clinicians adapt to this new model, learn from each other, have training programs, do the continuous learning that's critical. But you push back, Steve, if you disagree. That was just kind of my sense.
Yeah, so that I appreciate the invitation. I disagree. So
there you go.
So in a friendly debate here, okay, what we and it's in the data that you've just shared. We're not really looking, right? We don't have a way to measure the performance of these encounters. The people who are doing this, whether it's Helen's example of how to unmute your patients, at a minimum, or even like, I don't know how many of you have participated in telehealth. It's a skill set that not a lot of practitioners have ever received training for. And when you add that, and Atif, this is to your point, when you add that to what we already know about the abundant and complex gaps in practitioners doing what they should be doing at the right time, in the right way for the right patient, let alone interprofessional care coordination across teams. We know that for pain and OUD that those are really complex gaps and problems to try to resolve. So I do think that there's a need for investment and focus on how to bring the same kind of performance management, performance improvement, quality improvement approach, to this area.
Thanks so much.
We're out of time. I was going to respond, but I think
Please,
Helen, you
go
probably
ahead.
are going to.
2 minutes and I'll turn to Sarah to talk about access. It's all flowing together nicely, organically,
Yeah.
please.
All right. Well, I guess I would just say, in some ways, Steve, I'm with you, but then I just would say, this isn't exactly what you said, but I just want to make a point, which is that I'm often asked, do we need telehealth specific outcomes measures? And my general response is no. We just need to have the same clinical outcomes that we looked for we were generally looking at, and then we should assess the same models of hybrid care or whatever other model that we have. So I just wanted to make that one quick point there, because sometimes I fear that we need to assess tele or virtual care and how it impacts those outcomes, but I don't think we need specific outcomes unique to this care modality.
All right. Well, with that, thank you so much, Atif. You've definitely set up our small group discussion beautifully. I'm going to turn to Sarah now to kind of go through what we learned and heard about issues around access for pain management, SUD, and OUD. So Sarah, over to you.
Thank you. Everybody's presentations have been absolutely fabulous. I joined the chat and all sorts of a multitude of interest and conversations are happening, which is exactly why we do these meetings. So if that's a measure of success, we are already succeeding. So we're talking about this breakout is about access, and reviewing over the past meetings that we've had and some of the comments that were said today. We have challenges and barriers, and then we have opportunities. And in the challenges column, we have systems that are not designed to be patient-centric. And I would add to that, they're not provider-centric in the sense of what we were talking about before, the ability to administratively engage in treatment. We have problematic regulatory rules at the state and the federal level. You literally have 50 different ways plus territories for billing and providing care, including that you have cross-state telehealth differences and problems. There is a lack of access to specialized pain and addiction services in general. You have the double-edged equity sword on audio coverage only. And we have a lack of data on clinical and cost effectiveness. I would say there is a lot of data about cost effectiveness over the past 30 years, but there are these pockets that we need to do better at, and certainly with overall treatment. And then with telemedicine, we have to start drilling down a little bit more. On the opportunity side, we have the chance to bring payers together around member experience, around access to care, equity, quality, and program integrity. We have the chance to address the best practices in TBOT, as we've been calling it, and telepain care in building appropriate regulations and payment policies. We have the opportunity maybe to hold states and credentialing bodies accountable for clinical process metrics of programs they license and they certify. And, you know, we can talk a little later. I think the deprivation of funding of a lot of the state systems have been a big problem here, especially with credentialing. We have the opportunity to utilize virtual specialty care as extensions of generalist practices. We can develop best practices on diversion control protocols. We can work toward parity in telehealth coverage for SUD services. And we can improve the treatment of incarcerated populations. So those are the sort of buckets and challenges that we have. But as a work group, let's, you know, we have two questions, right? What are the additional challenges that we have, and what are additional opportunities that we have? So if we go through the buckets that we've described, we can either lump the ideas into those buckets, or people can just sort of provide ideas and then we'll bucket them on the back end. So what, you know, and we want to focus on what will be feasible. So one thing that I think is sort of crosses a lot of these areas is this idea of lack of access to medication and psychosocial care. Because that happens, when I was going through the meeting documents, that has been raised in the carceral settings. It's been raised related to buprenorphine. It has been raised sort of across a bunch of different meetings and slides that we've had. So does anyone have an idea for, you know, how we might address this? You know, like, how can the barriers be addressed? What levers do we have? What can we do to get around that? You know, what are the issues at work here?
So I'm not going to say anything because I'm going to be in your workout group.
Yeah.
So during that breakout group, as you talk through all of those kinds of things, I can throw out my spaghetti on the wall there. But, you know, particularly for those who are not going to be participating in that access group,
Yeah, sorry if I didn't make that clear. This is for sort of the broad group. These are the things we'll be talking about later, but before we get going, I want to get everybody's ideas on these issues, if they have them, that we can then cogitate on later.
This is Iris Berman at Northwell. I'm going to say that it's a lot of what we've already discussed this morning. It's a little bit a reinforcement of everything we've covered, which is really standardization of access in terms of the state borders. If you can't get it in your region, why can't you reach over the line as long as there's sufficient accreditation and licensure? Because again, goes back to some of the questions earlier. Standard of care shouldn't be different from state to state, region to region. I know it's idealistic to say that, but I do think we need to start working towards that.
Okay. David Tobin?
Yeah, hi, that's a great conversation, particularly about the incarcerated population, which is a real mess with people bouncing out, of course, and overdosing immediately. And lack of provider services and really a tough customer base generally. There is some grant activity going on now in the state of Washington to revise that policy. And though the process is mostly educational, basically train the staff as to how to manage pain, a lot of work done by their in-house pharmacists and the like, big training operation. So I think the big deficit has been no education about pain, and people report pain in all sorts of domains. I've got a different laptop, different base right now, but I'll see if I can locate the contact people working on that grant right now, because I'm sure they're interested in sharing that. The energy that giving this education has generated was phenomenal because the need was completely present. I mean, they're adding group physical therapy, group counseling, all the things we do in the pain world or try to do. And they're able to now introduce this right into their particular programs. We don't have outcomes yet. That's next. But just the enthusiasm and the energy that was coming from within when this was offered was, to me, astonishing.
Thank you. Anyone else? Just big items that we've missed, new opportunities that we haven't raised sort of within this list, or maybe more concrete examples of what those challenges or opportunities might be. I know the Medicaid managed care is a big issue. Medicare Advantage, we're now seeing some problems with that based on a new federal report that came out. Any other ideas? Okay, that's it then. Thank you. And we can move on to Anna.
Thanks so much, Sarah. All right, over to you, Anna. Thanks.
Well, thank you and good morning. Want to move forward one slide to there we go. Many of the themes from the access meeting that Sarah just highlighted carried over into meeting 3, which was focused on care delivery. And in that meeting, there was one overarching commitment from all the speakers that was really crystal clear, whether they were providing care for patients experiencing pain or providing care for patients with OUD and SUD, was that a hybrid approach in care delivery has to start with and be designed with a patient-centered approach. And each of the speakers, that was a resounding message from them, those that have scaled telehealth services or hybrid care, is that their care pathways and their workflows start with the patient in mind. And Helen said earlier that so much of what we've learned from the series is highly generalizable across all disease states. As I'm looking at the participants listed there's certainly experts in pain management and OUD and SUD, but there's also others that have lines of sight across the healthcare system and into other disease states. And so hoping that this discussion can drive innovation in other areas as well. But here's a general recap of those challenges and barriers, and then opportunities from the care delivery meeting. On the challenges side, it included difficulty in integrating related services, such as accessing mental health that's needed to support and supplement care, aligning patient priorities with payer and provider incentives. I'm sure that that sounds familiar across all aspects of the healthcare system. Creating new models that may result in more complex workflows that need to be worked through with needed support from both patients and clinicians. And then limited availability of highly skilled experts in pain management and SUD that was just discussed in that brief breakout, or the brief discussion just now. And then again, the theme that there's some regulatory limits that need to be worked on with regards to opioids, access to opioids, ability to monitor and have collaborative models of care. And then ending on some hope and recapping the opportunities is looking forward and seeing that there is this great opportunity to co-design new models of care with patients and clinicians that are innovative and patient-centric, that seek to decrease fragmentation, seek to incentivize collaborative care, and ultimately improve patient outcomes. Build coordinated team-based care approaches across disciplines, settings, and systems of care. Incorporate patient-reported data on symptoms and then outcomes into these new models of care. It kind of starts to lean in to that learning healthcare system that Steve Singer just brought up on our the last discussion, is what does the learning framework look like, and how does that continue to evolve as we build out these new hybrid models of care. And then working with public and private payer communities to incentivize these hybrid models for pain management and SUD, OUD care. And then lastly, to envision longitudinal care across the continuum, and versus more that episodic or asynchronous approach. So that's a recap of a 4-hour discussion last month that was really well received, and we had a lot of great discussion. I look forward to the breakout group having more discussion as well. And certainly if there's other reactions from participants who will not be in that breakout group, we'd love to have you share your thoughts now.
Just a reflection, Anna. This is Helen. I think I was just putting together the challenges and opportunities for the quality effectiveness work group after Atif's talk and our discussion. And it's interesting how similar those are, that if we really are talking about care delivery, how much of this is dependent on having data, particularly longitudinal data, to allow us really to put that evidence into place to push this forward. But great. I'm really looking forward to hearing what your work group comes up with in terms of what we could actually propose to move these issues forward for SUD and pain management. Thanks. Any other reflections from anyone? There's just so much on this one slide. So making sure there's nothing we're missing in terms of next steps.
Well, and if not, we'll look forward to hearing from those that are in the breakout group on care delivery.
Thank you.
Thank you so much, Anna. So we were behind and now we're not. Thank you all. Noah, over to you.
Great, thank you, Helen. And Bailey, if you wouldn't mind advancing to the next slide. One more, please. Thank you. So I believe, you guys, I think on Monday, I sent this to everyone to kind of start to get you thinking on these topics, but just a reminder, these are the questions. We'll also make sure you have access to these when you get into your breakouts. I do realize we have run a little bit over time. And so if we just move to the next slide, instead of a 10:40 a.m. coming back from the break, we're now going to be 10:50 a.m. We'll still have the full 30 minutes for discussion, but just kind of make up a little bit of time during the report outs. Just as a reminder, if you could all please stay logged onto Zoom so that we can make sure that you get sorted into the correct breakout group. As soon as we come back at 10:50, we'll kind of send you all out into your respective groups. So just really looking forward to this discussion and hearing your solutions, examples, and ideas about how we can move forward. So with that, I will let you all go have a bit of time to yourselves. Thank you.
Thanks, everybody. See you soon.
Okay, welcome back, everyone. We're about to get started and we'll be sorting you into breakout groups now. So just hang on momentarily.
But yours is more the specialist pertaining.
Grant.
Welcome back, everyone. I think if we can go to the next slide, we can get started with our closeout, with our report outs, and then our closeout discussion. So we'll just leave these discussion questions up, but I guess because I was in group 1 and our reporter was Hank Chaudhry. So Hank, if you wouldn't mind coming off mute and kind of providing a little summary of what our group talked about.
Sure. Thank you very much. Good morning, everyone. Can you all hear me? Just wanted to, we didn't have time to really vote on any of these ideas, but we wanted to share a summary of some of the things that we talked about. We talked about obviously the challenges and opportunities, but we also talked about specific areas such as maybe quadruple aim, patient satisfaction should be part of the metrics that we look for. We also need to make sure that there is value in the care that's being delivered through telehealth models, whether for pain management or for substance use disorder. There was also a recognition that with all the changes occurring at the state and federal level, that there was sometimes confusion among not only patients but providers about what's been happening and what is permissible. And so one of the ideas that came up was maybe there's value in having a central repository or a site, perhaps through National Academy, to help providers and patients keep up with these constant changes in legislation, which are continuing. There was also discussion of making sure that behavioral health providers get payment parity for the services they provide as part of a team care model. One of our speakers pointed out that looking at no-show rates for in-person care were very, very high in the context of pain management and substance use disorders, but telehealth made a dramatic difference in almost eliminating those no-show rates. And so when we talk about behavioral health providers, looking at nursing, looking at PharmDs, social workers, physical therapy, occupational therapy, and others may be something we need to look at. At the same time, we were reminded by one of our speakers who is from CMS that there are some challenges related to that. And so we were reminded that much of how that sort of decision-making proceeds is through rule. And while we desire, while CMS and others may desire disciplinary care, there are questions that are raised sometimes about, for example, how is the reimbursement actually configured and who does it go to, for example. Regulatory inconsistencies between and among states was brought up. Sometimes that is perceived to be protectionary, and we need a federal intervention perhaps that's more consistent. And then also another area of vision out there that's a challenge, but an opportunity in terms of education and awareness is that telehealth and Medicaid, there's been a lot of flexibility during the pandemic in terms of what Medicaid has been enabling in terms of telehealth. States, however, many states have tied their rules to Medicare instead. And so educating states, educating providers has been a challenge, but an opportunity in terms of understanding what they can and cannot do. So looking at effectiveness, value, and accountability, all of those are important, but these are some of the highlights of what we talked about. And there may have been things I left out, so I'll let Helen or others comment. Helen was the chair of the work group. Thank you.
Thanks so much, Hank. That was really comprehensive. I'll just add a couple of things that we had on a quick slide we had at the beginning, which was also just thinking about in terms of opportunities, how we might be able to look at data and the importance of sort of new interoperability rules that are forthcoming that may allow us to actually, I think the term was to broaden our aperture, really be able to see progress overall across systems, across clinicians, across providers. I thought was really an important consideration where I think there are some data issues that we could really have clarity on, both clarity around definitions of telehealth and SUD services, as well as clarity around the different modalities and whether they may have differences, different impacts on some of our assessments of effectiveness and value. A little bit of discussion about thinking about new models around value-based purchasing. And I really just want to put forward a comment that Cherry made that I really found intriguing, which is sort of this is really about effectiveness and value. And her point was, can we sort of identify the outcome we want to see and kind of work backwards and think about what services need to get put together to make that happen. And she really emphasized, I think, the importance of recognizing that there are, clear comments and rules that need to be done, but thinking about that in that broader context could be really useful. Let me just see if anybody else on the work group wants to add anything to Hank's very comprehensive assessment. All right, excellent.
Okay, thank you, Hank, and thank you, Helen. I believe the report for group 2 is Kelly Clark. So Kelly, over to you.
Okay, well, let me see what I can get through, and I think we've got adequate time to get through this, so I'm not going to talk as fast as usual. So our group talked through a number of kind of bigger picture or thematic issues that arose from the little pieces of what's the problem and who owns the solution that we talked through. So one of the things that we talked through was primary care doctors who are doing so much are not doing some of the things that we would like them to do in these fields. So we talked about some of this screening that is part of, say, the Medicare annual wellness visit, which includes, screenings for substance use disorders and et cetera. And less than a quarter of their Medicare beneficiaries are getting claims on systems for those in a year. And so we can't do the issues of why. And this is a research question. Why? What are the things that are getting in the way of primary care doctors doing the things that are being incentivized, or that we would like them to do as part of their incredibly busy kinds of practice? So, are the other issues of what we would sort of love them to do is to be treating pain and pain patients rather than trying to refer out or not accepting pain patients who are coming in from specialists, and similarly treating substance use disorders. And our hypotheses around those included, that things might be a free service for the Medicaid beneficiary, but there's a lot to be required of the provider. So our payment high enough to incentivize the providers to provide the service? Is there stigma still in asking about substance use disorders? We talked about how, one of the problems with SBIRT is always the ERT. You can screen, you can do a brief intervention, but referring to treatment is always a problem. And it's down to the question of, if I screen, it screens positive, then what? And so really finding, and we know we've got some data on those, rural doctors not prescribing buprenorphine because of fears of the government oversight. And someone else mentioned issues of government oversight and fear, keeping primary care doctors from treating pain with opioids as well as treating addiction. But the research that we need to do on that seems to be pretty substantial to identify what those barriers are so that we can get around those barriers. Talked quite a bit about something that I'll just call the federal government not being in great communication with practitioners out in the field on something. So, for example, there's sort of a lack of understanding by providers in the field about the 988 and the rollout there. Community providers are going to really be needed to make referrals into the program, and community providers really don't know what the federal government's doing, or grants or programs and things. That's not part of how community providers normally live. So how can we sort of bridge those gaps? And that would have to go back to feds to try to do the research and figure out how to bridge those gaps. But a similar thing with the contingency management thing, which is sort of rolling out now with some states being sort of required to cover contingency management, but which would be great if it were done in an evidence-based manner, but there's a limit of $75 on the patient, which is grossly inappropriate and inadequate and is nowhere near the evidence base. So rolling out something that looks like it's going to be fail and just undermine what is really a well-known technology is problematic. So there's something about that piece of that's a larger theme that we identified here. Also talked about the one problem in getting access is the amount of time it takes for a treatment program or provider to get licensed in a state, which lives with the state licensing, which is often underfunded, and then the amount of time it takes for them to get credentialed by a health plan. And there are issues where a provider who might work in different companies, different environments, would be re-credentialed under each of those different plans. And why is that necessary? If the provider with their NPI is credentialed, they should just be credentialed, and that would live with the health plans to show that they're decreasing that credentialing time, while of course continuing the credentialing process to make sure that they're getting appropriately credentialed providers for their member population. We talked a bit about the issue about how do you get people into care. You're talking about the Atlas program of Shatterproof, but the previous issue is how do you get people to want to go to care, which is an issue for our research data metrics group that we discussed early in the collaborative. So how do you get them to want to go to care, and then how do you connect them to care? But the underlying big issue is there isn't appropriate, adequate care to send them to. That we've got that utter lack of treatment infrastructure, was discussed in the ecosystem NAM paper mentioned earlier today. So the people who sort of own that of the treatment we have, far too much of it is not evidence-based or not even minimal quality. And so who owns being able to do that, to build access to an appropriate treatment piece for pain and SUD programs and providers? So some of that lives with the state, which should be responsible for the actual active oversight of those programs that they are actually licensing, which too often they just don't do because of fiscal constraints and lack of clinical leadership to be able to do that. So the states own that. The payers own making sure that they've got whatever an adequate network would be that's possible, and not paying for the care that's not helpful or is harmful. But also the purchasers, which includes the federal government and employers, to make sure that they're holding those payers accountable to the appropriate process metrics and outcome metrics. And we went back again to those issues of we need to build those appropriate process and outcome metrics, and the builders of those are always specialty societies within any medical status, but also then the larger groups. Could it be NAM that could help to put that together? Could it be live within SAMHSA to put some of that together? Could some of this live in other places in HHS to help bring the right stakeholders together to put this together? And then back to the lack of treatment infrastructure, we're going to go back to the university hospitals and medical schools and residencies, and I'll say psychiatric residencies, et cetera, for not training around addiction and pain, and not building the training for the totality of workers, the social workers, the physicians, the nurses, to work in this field because it's less lucrative. And that goes to who is financing those institutions. That's who owns that issue. And then we had a really great, I thought, a discussion about how from Lisa about what the Federation of State Medical Boards is doing, reworking their sort of best state regulatory practices on opioids and opioid use disorder. And they're doing this not in a vacuum. And this was sort of a key thing, right? They're doing this with the pharmacists. They're doing this with addiction doctors. They're doing this, with those very broadly with different stakeholder groups who actually have something to say about this and have knowledge about things in the field that need to be baked in to state regulations or state model regulations that might not just come out of a more insular group. So that who owns it comes down to each organization that's doing something owns that, reaching out to the other stakeholder groups that have something to say and have something to bring to the table in building it what that place is. And I will stop. I think I covered, oh no, I missed one. Using the zero suicide model and putting that in as we think about approaches to OUD and chronic pain. Just sort of tried to co-opt that model to a different group, sort of made some sense. And then finally, we talked about the huge issues with the EMR. We talked about the groups that were left out of the HITECH Act, typically the behavioral health providers, need to sort of be prepared that electronic medical records are kind of coming. They need to prepare the field on that. And we need this to happen because we need to start integrating the physical and behavioral health data, information, medical records, and that lives with state regulators and legislators who have firewalled away behavioral health from and particularly substance use disorders from the rest of the medical record. That lives with the feds, who have done those with federal regulations as well. That lives with EHR vendors because of our need of interoperability, and the purchasers of healthcare, the providers who are using those EHR programs, to make sure that they have the appropriate interoperabilities. It lives with the payers to break down their silos between their databases, between the behavioral health bucket of claims to be done by only behavioral health providers certified, and the medical bucket of claims to be paid by all other medical health providers. And the need to put that at that patient level to really drive our understanding in the data gathering. We need to do all of this. So now I'll stop and ask Sarah, who chaired, if I missed anything, or anybody else in the group if I've missed something.
No, I would just clarify that the state opioid response funds are permitting providers to implement CM, contingency management. They're not requiring it, but your point is still relevant, which is that they're permitting it, but they're also capping the funding at $75, which is not evidence-based. The other thing that I think I raised many meetings ago, it didn't come up, but it is something maybe for this group to consider, is this issue that, almost half the treatment system is for profit, but the full focus of federal and local governments is really on the not-for-profit sector. And the problem with that is that the not-for-profit sector really can't scale up treatment in the way that the for-profits can. So for good or for bad, that's just kind of the way it is. And the for-profits are also pretty demonized in many sectors. And I think that when we're looking to really change the system, you can't just focus on half of the system. So I'll just throw that in there for what it's worth.
Great point, which goes back to the National Academy's Action Collaborative here, which is a public-private partnership. And we have worked, particularly in this telehealth group, we have worked really diligently to bring together as many different kinds of stakeholders as possible to make sure we're balancing tax-paying organizations and non-tax-paying organizations, as well as all other kinds of considerations. But excellent point,
Thank you,
Sarah, about scalability and flexibility.
Thank you, Kelly. And you did an amazing job of summarizing that very wide-ranging conversation. Was there someone else I thought maybe who had a comment?
I think just for the sake of time, to make sure that we can hear from all groups, I'd like to move to our third group, which is focused on care delivery. And I believe Rhonda Beal will be that group's reporter. But thank you, Kelly and Sarah, for those contributions. So Rhonda, over to you. Rhonda, you there?
Okay, sorry, I had to make sure I was off mute. So ours was on care delivery, and we started the conversation with perhaps modifying the thinking of care delivery as really being care delivery system. The reason being is that there are so many different components, and we've talked about previously the multidisciplinary, multifactorial way that we're approaching this, that in order to really be able to proceed with this, we really need to look at it as a system of care. And that's where we're able to pull the pieces together to work together to produce the outcome, the desired outcome that we're all looking for. There were several different pieces that we talked about in relationships to this, one of the things that was laid out was what is the organization by which, or how do we organize this in terms of looking at practice, the care delivery system, and what are the elements that are very important in terms of being able to pull that together into an effective system. So we brought into play the standards of care that was promoted way back when ACA was coming into play. And those standards of care dealt with several pillars. Data is one of them, and data is essential in terms of being able to record what is being done from a process perspective, but also hopefully from an outcomes perspective, and needs to be standardized so it can be cross-compared across providers, across systems, across the country, across provider types, pretty much like what you would say with a registry of some type. Also looking at data as being the basis of creating transparency. The transparency takes the data and creates information that lets one know on a provider level how they're doing and how the patient gets them to know how they're doing. So it's on a patient provider level, but also on a provider practice level, so that one can see in comparison to other practices how they're doing, but also most importantly, what's possible. In running capitated practices back in the 80s, it wasn't until there was differentiation in performance across the different groups that one began to realize it is possible to decrease hospitalization and ER rates and improve outcomes as it relates to patient satisfaction. So it's those types of transparencies that helps providers and systems to understand, yes, it's possible, and I'm not doing what others are doing, and maybe I need to change or learn from others to refine what we're doing to improve. So it really promotes improvement. It also promotes learning. The more fine-tuned the data, the more one is able to learn, and it becomes the background by which you bring your multidisciplinary team together to discuss what's going on as it relates to the patients that have gone through your system, not only from a quality of care perspective, but how the system itself is working and how effective it is. Accountability is exceptionally important in terms of making systems accountable for the populations that they touch. This allows one to define the population, but also sets the basis for alternative payment. Alternative payment is exceptionally important because without an alternative payment system, it does not allow the systems of care to be flexible enough to be able to mold and change what they need to change in order to be able to deliver the care and achieve the metrics that are ultimately decided upon. It's very clear that in looking at capitated and value-based practices against fee-for-service practices, there's a vast difference in the types of services that are supplied in a capitated or a grant-run type system, where they are allowed to nuance the care to their strengths, but also to the outcomes that they're trying to achieve. So along with that, we talked about flexibility. We also talked of payment. We talked about being able to identify the types of different services that are within a practice. Right now, the current system of contracting doesn't necessarily highlight that. And so therefore, it's one of those things that is unknown to the payer, unknown to the providers, but also unknown to the patients themselves. So if one is going to allow through some type of alternative payment system where you have your guardrails set up with your data and your metrics and your transparency, you're going to need to be able to have a system that allows the difference in terms of types of approaches to be well known. It also needs to be a system that allows flexibility, because providers may change the types of approaches that they take with a patient based on what they learn or based on shifts in their staffing in some way. Let me make sure we talked about, I'm gonna stop now to see if I have missed anything. Oh, federal regulations, we talked about across states. Consistency across states is being absolutely essential in order for providers to be effective, particularly in the populations, and also dealing with patients who travel. one of the issues that was brought up is being able to not only see patients across state lines, but also to be able to issue medications across state lines if one is not licensed in that particular state. So I think I'm going to stop now to see if there's anything that I missed from those that participated in the very, very enriched conversation.
Thank you, Rhonda. Anybody else from group 3 have anything else to add?
I don't, but Rhonda did an exceptional job summarizing. We had such a good mix of the payer perspective and the provider perspective. And so it was a great group.
Thank you. I'll now turn things back over to Helen and Kelly to bring us home, or maybe continue the discussion for the brief amount of time we have left.
Wow, that was a lot. Thank you all so much. We've got, I've been trying to take notes on what a summary would look like, and it just keeps getting longer and longer because your presentations were so complete. Maybe I'll just start on very general high level themes and turn it over to Kelly about actions. But I think we consistently heard that we needed to consider some really important issues around understanding integration with other services, integration with other types of providers, multidisciplinary coordinated care, the importance of having consistent definitions and its impact potentially on both data as well as outcomes, needing funding for those research outcomes as well. The importance of transparency and shared resources, shared accountability, and the overwhelming importance, not surprisingly with Hank and some of his colleagues here, the overwhelming importance of these state level issues, both in terms of what is the current state of play and the lack of knowledge about what it is for both clinicians and others and payers, but also recognizing that there still are some unsolved issues where greater consistency would be really useful. And I'll just end one other comment, since we started the day around effectiveness, and Atif's talk will sort of end with that. I just want to emphasize something David Taubin said in our small group, which is it really should be more about the quadruple aim as we really think about how we're going to assess the value of these telehealth hybrid services for both telehealth and pain management. And I'll turn to Kelly.
Yeah, I don't know what else I can say. You know, I think the thing that it was most striking to me as we've gone through this is that our discussions, whether they were focused on telehealth, actually are based on general medical principles and our general health system principles. That so many of the things that are problematic whether there's virtual care involved or not. And we kept going back to those very fundamental problems with our system in terms of the regulations, in terms of, you know, the clinical challenges, in terms of payment challenges, and ensuring the value of quality and cost management. So I think that was probably the thing that was striking to me about this whole series, is how much we kept coming back to core issues that we have with our healthcare system. And the telehealth or virtual health pieces are just adding on top of those. And if we don't get these kind of foundational issues done, then we're, you know, just building a house of cards on top of a camel who's, you know, one card away from having its back broken, to totally mix metaphors.
But it kind of works, so it's okay. I completely agree. And I think in many ways, we've also learned how, yes, these are generalizable lessons of the healthcare system, but even in the telehealth space, how much the use of our sort of tracer conditions of chronic pain management, SUD and OUD, brought out all these issues, which is really interesting as well. So I think as we write up these sort of final conclusions and look at all of our notes, I think it's interesting to reflect on the different layers, that there's some elements about this that really are about state flexibility, et cetera, that are across the board. And there are some that are going to be very specific to moving forward, what we can do. All right. I see David has a comment in the chat about thinking about which funding agencies could be potentially willing to support some of the needed research we're going to need around effectiveness, value, accountability for some of these different care models. wonder if any of our NIH colleagues are still with us. I saw someone earlier, but Kelly, anything you want to add from the research and data metrics group?
Yeah, I'd like to actually broaden out the statement from federal agencies, because we think about the federal agencies in terms of those that support research, and that's true in academic environments. But the truth is that payers have an enormous amount of data. But what they don't do is get together and decide on, how to utilize those data together, and what some of the metrics are going to be together. Now, there are antitrust issues, et cetera, but just as an example, payers coming together to look at and provide research across the board could be extremely effective. So I'm just asking folks here to think very broadly about funding models beyond where you would think in terms of normal federal agencies.
Great. And I saw we had a hand up from Leonardo from NIH. Would you like to share any thoughts, Leonardo?
And I see that there was thank you. See, there was already a response from Sarah, but on the NIH side, and certainly within the small business, we definitely look into effectiveness and value proposition of whatever project is brought, research product, and make sure that is the research that is conducted is to solve a problem and then brings the product to the patients. So we do take into account not only regulatory hurdles, but also reimbursement hurdles. And we have, for example, presented a concept that was approved by our council, which is specifically focused on payer reimbursement for digital therapeutics. So we are definitely also focusing on that aspect as well.
Thanks so much, Leonardo. I think the chat also indicated there's other places as well to consider, different institutes within NIH, HRSA, ARC, SAMHSA. And I think, a lot of what we heard earlier on from, I think, some of our colleagues from CMS, as well as really the ability to think prospectively about putting into some of the responses to calls for comments on proposals, what's needed. And we might be able to assess that effectiveness. Something Sherry said was, you can sort of assume if things are out there in a rule, they're already deemed effective because they're in a rule. So, how can you work with Sherry? Maybe Sherry, if you want to just feel free to chime in. I really found that comment really helpful around thinking about sort of generating real world evidence that allows payers to sort of move us forward. Thanks.
Yeah, and I think, Helen, you said it much better than I ever do. So thank you for that. But, just to say it, I think there's a matter of fidelity in the understanding of what is covered, what services are available and already, and just noting that there are layers that are between the evidence and actually receipt of a care and service at the point of care for the people who we serve, and really understanding what those impediments might be. And in the area of pain care, this is exactly what one of the Support Act provisions points out, which is 6086, the Todd Graham provision. What are the impediments and barriers to evidence-based care and services? And I'm paraphrasing there, but I think the challenge that we have is that some of that may not be knowable by way of traditional research. And this would be a great opportunity, for those of you who work in health systems to ask the question of themselves. So, this is provided by the evidence. This is supported by the evidence. These are covered services. So why aren't we using those codes and taking advantage of the opportunities? So I think that really gets to also systems learning and identifying also where it's working and where not so much. So we all can keep a focus on, improving outcomes for the people who we serve. So thank you so much. And thank you so much for all of this work. Tremendous conversations that I always enjoy. And our team is on and just speaking for them. Thank you.
Much, Sherry. Thanks for engaging and having your team join us today. Kelly, anything else to add? Anything else? Any final words from any on the group? We have a lot to take in across all these work groups, and we'll put something out to share with all of you. Anything else you'd like to share? We'll share these links as well.
So my last words before we go over is just thank you to everyone involved in this series. Thank you for the work group members. Thank you to the staff. Thank you to Helen for all the hours, pleasant hours. And for everybody for really participating. I think this has been a really interactive series with a lot of different viewpoints, and we've gathered a lot of slides, a lot of talks, a lot of just data for you to use and turn it into your knowledge as well. So those are my last words, Helen.
Agree. Noah, you want to take us home? And just special thanks to Noah and Aisha. Obviously, we put a lot on their plates over the last 6 months to get this 4 webinars done in really rapid fire. So anything else you'd like to add, Noah or Aisha?
I just wanted to extend my gratitude to everybody for participating over the last several months in this series. As Helen and Kelly said, we've gotten a lot of information, and we're really excited to kind of try to capture it all and put it out in a report. And really do encourage you all to stay engaged with us on this topic. By now, you probably all have my email address. And so definitely if more ideas continue to come up or more resources that you'd like to send our way, we will continue to take them. And then lastly, we will be posting the slides from today, as well as the recording onto our website, where also all the other materials currently live. I just posted that link in the chat if you haven't already received it. We have also been developing discussion proceedings. I think you've seen some of the early drafts, but we'll be publishing the final one soon and make sure that you have access to that as well. But again, thank you all so much. And we look forward to being in touch with you all soon. Thank you.
Great. Thanks, everybody. Appreciate your participation. Bye.